Members, it is about time we have attained the quorum and now call the meeting to order. Item number 1, information papers issued since the last meeting. There are 2 papers there. One from Honorable Alice MAK, dated June the 18th, on internal allocation of utilization of resources by the hospital authority. If I recall, towards the end of last meeting, there was a request for the hospital authority to give us an update. I think we have to leave it till after the summer recess. We'll have a word with the secretary to see when we'll come back for this after the holiday. The other one is the information paper on the provision of cataract surgeries. There was a member of the public raising the issue of cataract surgeries. The HA's reply has been made available to members beforehand. The question is whether we should put this item on the agenda going forward. That's about the cataract operations. If there are no strong views, well, Chairman, I think we can keep this on the outstanding list of items. I think it's a good idea, because this is dear to the heart of the members of the public. And maybe because of air pollution and environmental problems, people tend to suffer from cataract problems as they get older. Whether there is an increase, I think with the aging population, the instances have indeed increased. I think we can put this on the list of outstanding items. We will have a word with the secretary after the summer recess to see whether we can have an agenda item for this. Mr. Vincent Fang, a couple of days ago, wrote to the panel for a meeting to be held on the distinction between beauty treatment, medical beauty treatment, and beauty services, and also the working group and so on. I think we did have a public hearing. There is a working group under the steering committee which is tasked to look at the distinction between medical beauty treatment and beauty services. According to the administration, as soon as the findings are available, they will come back to us. Mr. Vincent Fang is not here with us yet today. We haven't got anything new from the administration. So do you think we have to hang on until information becomes available before we put this on the agenda, or what? So we'll wait the information to be forthcoming. All right, that's how we proceed. All right, then item 2. We don't have to decide on the items for the next meeting because this is the last meeting for this year. Dr. Quat, I thought you were talking about the next item. All right, the next item, an overview of the redevelopment and expansion plans of public hospitals. The admin's paper and the background information have been made available. Shall we invite the secretary in, please?
歡迎
Welcome, Secretary and his team. Secretary, if you're ready, please take us through the paper. Thank you, Chairman. Chairman, members, the paper seeks to explain to members the redevelopment and expansion plans of the public hospitals. I'd just like to say, first of all, that this paper is about public hospitals. Today we're not dealing with private hospitals, but I'd just like to set the scene by saying that for this term of administration, the healthcare policy builds on the policies or the consultation conducted with the general public by the previous terms of administration, and there was a consensus that in Hong Kong we probably are not going to have any revolutionary healthcare reform like the compulsory healthcare protection scheme or the healthcare saving scheme. They were rejected during the previous consultations. In this fourth term of administration, on the basis of this consensus, we proceed with this dual approach, comprising the public and private hospitals. The public hospitals represent the safety net for the members of the public, whereas the private hospitals take up about 10% of the services. And the level of services that they provide is less than 10% of the overall picture. So on the basis of this, our role going forward is to make sure that the development of services in the public and private sectors will be sustainable and healthy and balanced. So with this in mind, we are dealing mainly with the public hospitals today, but we are not losing sight of the fact that there are hospitals in the private sector. We have to maintain the development on both sides of the equation. We may be talking about hospitals in the public sector, but I hope the members would not get the misconception that we are merely focusing on public hospitals at the expense of private ones. Public hospitals are very important because they are the cornerstone and the safety net for the members of the public. So the government has to be committed to these hospitals so that people will not be denied the services because of lack of means. So we will adopt various measures to increase the services and to renew the facilities to meet the needs of the public, to balance the public and private sectors. We'll have to adopt certain measures like the voluntary medical insurance scheme. Other than that, the provision of healthcare facilities would also be important. If we merely set up public hospitals but not private hospitals, then the focus will be skewed towards the public ones. Conversely, the focus will be on the private hospitals. So we have to strike a balance between the two. Now today we are talking about hospitals in the public sector. In expanding the facilities of the public hospitals, we have quite a number of hospital redevelopment and expansion plans. The Zhangguanlong Hospital is being expanded. The phase 2 of Caritas Medical Center and the redevelopment of Yanchai Hospital. All these are ongoing projects. New hospitals under construction include Tin Shui Wai Hospital and the Center of Excellence in Pediatrics in Kai Tak Development Area. All these projects will, in the coming year or 4 to 5 years, be coming on stream. Upon completion of these projects, the services provided by the public sector will increase in terms of quality and quantity. Other than the projects that I mentioned, we are also actively planning for a number of projects that have been committed. They include the expansion of the United Christian Hospital, the redevelopment of Kwong Hospital, Queen Mary, and Kwai Chung Hospital. Faced with the growing population and the aging demographics in Hong Kong, together with the technological development, there will be greater demand for medical services. The hospital authority will further review the services and facilities of the existing hospitals and plan for the anticipated demand in different districts and come up with a medium-term and long-term development blueprint. In particular, I'd like to highlight the fact that at the Kai Tak development area, in the vicinity of the Center of Excellence in Pediatrics, there will be a large-scale acute hospital to cater for the increase in demand arising from aging demographics in Wong Tai Sin and Hong Ham. In NT East, we will conduct a review on the service demand, and we've decided that in Tai Po and Sha Tin there will be an expansion of acute and convalescent facilities. In Prince of Wales Hospital, Sha Tin Hospital, and Tai Po Hospital, within the footprint of these hospitals, there is potential for further development. We can carry out expansion within these sites for acute and convalescent services. Prince of Wales Hospital, the original Phase 2 project, has not been escalated to the highest priority, but after some review, we found that the Sha Tin population in Sha Tin has been increasing pretty significantly.
At present, the next phase of redevelopment of PWH should take into account an expansion element. As for convalescent beds, there aren't enough such beds. Therefore, in Sha Tin Hospital and Tai Po Hospital, there's a need to expand. In view of the development in Fanling North and Kutong North, and also the growth in population, land has been reserved in Kutong North. Our priority should first be put into the expansion of the North District Hospital, but in NT Northeast we have received land for medical facilities. My apologies. I think I should move on to Lantau. In Tongchong, i.e. in North Lantau, the North Lantau Hospital is planned to commence operation this year. In view of future population growth, it is possible that next to the current North Lantau Hospital, land may be used may be earmarked for future expansion of the hospital. I think there is another project, or rather another site, which has been earmarked in Tai Po for a private hospital. Earlier on, the site for Wong Chuk Hang was awarded, yet the Tai Po site was not awarded because of a failed tender exercise. We have actively reviewed the situation in in NT East in respect of demand for a private hospital. We are now assisting the CUHK in respect of a site given to the CUHK, not the original site in Tai Po, which was earmarked for a private hospital. Now there is a site which has been given to the CUHK, and they propose to build a teaching hospital. We are actively pursuing this course with the CUHK. The Bureau, therefore, is of the view that in Tai Po, it may not be necessary to reserve another site for a private hospital, assuming that that plan goes ahead. As for a public hospital, we have talked to the hospital authority, and in fact in Tai Po Hospital there is room to expand its rehabilitation service if there is such a need, and therefore there is no need to keep this site in Tai Po, which was reserved for a private hospital. This site, which was earmarked for a private hospital, will therefore be returned to the Development Bureau, and the Bureau will look into other kinds of development. I may not be able to answer all your questions, but I'll stop here and then I leave some time to answer your questions. Thank you. Now, according to our experience, many will ask questions. 9 already in the line. So I will limit the time to 3 minutes each. Elizabeth Kwok, Alice Mak, Chung Kok Chu, Chen Hang Pan, Hu Chi Wai, so on and so forth. Elizabeth Pratt. Now, I've heard that the administration has a lot of plans for redevelopment and expansion, and we support all that. And I also support the cooperation between the public sector and private sector, and they're important. Since time is limited, I'll focus on PWH. Now, PWH is in dire strait. I believe the Bureau has heard that, and we've received a lot of complaints. PWH isn't just serving Sha Tin. It serves the whole of Sha Tin, of NT East, and even cross-border patients. Apart from serving the residents, it is also a teaching hospital. Waiting time at the A&E department is very long. In March and April, DAB interviewed 354 patients at the A&E department. Many complained that the waiting time was at least 5 years and sometimes 14 hours, and they will have to wait for 24 hours to get a hospital bed. And this is the chart. For hospitalization in the medical ward, the average age is 70. The curve is shooting up. When the age of patients are rising, they need different kinds of services. The number of patients has substantially increased from 2012, 2010-11 to 2011-12 to 12-13. Patients increased by 8,000, beds increased only by 4, and doctors only increased by 8. So if you compare the rise in number of patients vis-a-vis the rise in number of beds and doctors, you see the situations is rather acute. In PWH, you can see that all corridors are filled with beds, and also some boards, partitions, and these partitions have become have paintings and posters on them. Patients really can't wait. Just when can the review be completed? And how can you speed up the expansion of PWH and increase the number of beds? As for the expansion of Cheung Kwan O Hospital, there isn't any doctor for the gynecological department. And I really hope that you can solve this serious problem. As for PWH, the Phase 1 redevelopment started in 2007. There is a 14-story main clinical block. It was completed in 2010. And the new block is now being put into service gradually, and is already filled to capacity. Is already not adequate. This second phase is not for expansion but rationalization of service, but we've already changed that. Our understanding with the hospital authority is to plan to expand the number of beds, and how many additional beds are needed. I don't know whether Dr. Low or Dr. Zhang is able to provide the data, but we really don't know. And in fact, it's not just the PWH. The shortage of hospital beds is common to other public hospitals. Nearly every cluster has a very high usage rate, and we can see that after 20 years, we have to take care of the population after 20 years, and we are therefore very actively reviewing the blueprint for hospital development with the hospital authority, and we found that many hospitals have to be expanded. And that includes a lot of calculation, detailed planning, and setting of priorities. And there are competing priorities. I don't know whether Dr. Zhang has anything to add, but I have to apologize that I can't give you any definite timetable. Among all the plans, the most specific I can get is the Cataract A&E Hospital. This is the first priority. Dr. Chung, is there a timetable? As for the short to medium term, concerning the medium term, different hospitals have space for expansion, and we should look at that together with phase 2 of PWH. In 2013-14, there will be 30 ambulatory beds, and in 14-15, there will be more beds for PWH. Mr. Tan Chiang. Thank you, Chairman. I want to ask the Director of Bureau concerning redevelopment and expansion. There are many of them. UCH, KWH, will soon start the works. They are now being planned. There may be other plans, or there may be other expansion programs. Should we continue to build big hospitals like PWH? PWH is already very big in Southeast Asia. Not too many are as big as PWH. Will you consider smaller but specialized hospitals? I think there are many elderly people going to PWH. For one reason or another, they go to the hospital. But they are elderly people. Can we have a hospital for elderly people, say a geriatric hospital? So you just have a geriatric hospital somewhere else, and so you don't need to expand PWH then. Well, it's not so simple.
Well, can we have different specialized hospitals? At the moment, we have an eye hospital, which is a specialized hospital. The Kent Hospital on orthopedics is also a specialized hospital. The new Center of Excellence in Pediatrics is a new specialized hospital, but they require different technology. For geriatrics, there is an area which involves high technology, but we have to deal with the sheer quantity. Given the rapidly aging population, long-term care and convalescence are the areas that we have to consider increasing the quantity for. Should we concentrate all the elderly people in one single hospital? I haven't seen any success stories that we can learn from the world over. So we do have large hospitals, major hospitals. We also have a small but specialized hospital. But your model, I don't think I can apply this to any particular area. I still have time. No 4 minutes, no 3. Yes, really. But he used up all my time. I thought I had 4 minutes. I said 3 minutes. There are 9 members on the list. If there is, we may not be able to have enough time. 3 minutes. Miss Alice Mack. Chairman, we've been discussing the specialty hospitals, and we were told that there is a shortage of doctors, and we can't have specialties of one kind or another. So will there be a sufficient number of doctors to cater for the different specialties? Second, in United Christian Hospital, Kwong Hospital, they will be redeveloped. I think QEH would be a little bit better because the Kai-Tak new hospital will share part of the load. For other hospitals, they will not be in the same position as the QEH. What about the Princess Margaret Hospital? I was told that it is chock-a-block, full of people bursting at the seams. Will there be a new hospital that will be collaborating with the Princess Margaret Hospital, like the case of QEH? And Hong Kong Buddhist Hospital and Kwai Chung Hospital redevelopment. I said many times here that upon redevelopment of the Kwai Chung Hospital, the facilities will be improved. At the moment, it is really horrendous. The patients told me that it feels as if they are in prison staying there. The other one is the Hong Kong Buddhist Hospital. I'm wondering whether there are any hospice wards that will be provided at the Hong Kong Buddhist Hospital. Upon redevelopment, will there be such facilities if they do not exist already at the moment? I heard that there are some at the moment, but will the scale be increased? Secretary, I think Ms. Alice Mack has got a point. In Kai-Tak Hospital and Queen Elizabeth Hospital, by the time the Kai-Tak Hospital is completed, the QEH will undergo redevelopment. We can make such an arrangement as to make the QEH redevelopment smoother, and we don't really have to proceed in a fragmented manner like other hospitals. So we do need to have hospitals in the same cluster. The Kai-Tak Hospital will take over some of the patients that meant for the QEH. I'm not sure whether there would be such opportunity for Princess Margaret Hospital. What about the Twin Moon Hospital? There will be site available for new hospitals in Hong Shui Kiu. Well, these are a little bit different. We have to maximize the site potential. In Twin Moon Hospital, it does have room for expansion. QM and QE, there is no further room for expansion. In the Kwai Chung Hospital, indeed, the mode at the moment was institutional custody because they were concerned about the patients running or escaping from the hospital. When I was a junior doctor, there was very much some kind of worries that the patients might commit suicide and so on. Right now, the environment will be improved, and they will be given an opportunity to engage in social life and for them to be reintegrated into the community. For the Hong Kong Buddhist Hospital, I defer to Dr. Zheng as to whether there is any hospice care provided. Chairman, there is a hospice care at the Hong Kong Buddhist Hospital. Upon redevelopment and refurbishment, this will be upgraded. Now, for the hospice care, other than hospitalization, we attach a lot of importance to home care as well. Dr. Fernando Zheng. Chairman, thank you. All these hospitals that we mentioned are either undergoing redevelopment or expansion, and there is so much that has yet to be done. It shows that the previous administration didn't do a thing at all. We don't have that many new hospitals being built, and we are awaiting the pediatric hospital, and coming up will be one in Tin Shui Wai, and one in Dongchong. We have been arguing ourselves, our horse, for this to happen all these years. Expansion and redevelopment are really good idea. We will support them, but with the hardware being built, they're not really opening it up for service. Like Parkway Hospital, the North Hospital, they have not been utilized to their full potential. I went to the golf course, not for golf, but for protest. The taxi driver told me that the North Hospital is a good one, but the pregnant women have to go to the Princess Margaret Hospital. He did take a couple to the PWH, but it was very congested on Total Highway. The pregnant woman was in a very desperate situation. She was in labor, and in the North Hospital, everything is in short supply, and there is even a shortage of commodities there in the North District. With the hospital being built, will that be matched with sufficient manpower? Will there be sufficient number of doctors, sufficient software to tie in with the hardware, and the patients don't have to travel a long distance for the service? And the neurosurgical service seems to have disappeared. At Kai-Tak, there is supposed to be a specialty for neurosurgery. I mean, there are so many questions I'd like to ask about the Shenzhen, Hong Kong U Shenzhen Hospital. How much manpower has been diverted away from Hong Kong? Secretary, well, Dr. Zheng's question is about the manpower supply. Perhaps I answer this together with the one raised by Ms. Alice Mak. Manpower is indeed an issue. As members are aware, in the year 2000, the beginning of that year, there was an economic downturn. There was a time when we slashed the quota for the medical school. Now, this is one of the factors, and as a result, we run short of doctors. We also run short of nurses, but for nurses, at least we have a training program which is not as long as the training program for doctors. So in the coming 5 to 6 years, we're going to be in for a very desperate situation. The hospital authority has recruited about 200 new doctors, but they will fill the wastage over the past year. So the shortfall will still be there for the coming 5 to 6 years. Starting from last year, we have a longer-term manpower planning, but that doesn't really address the problem for the immediate horizon. In the previous term, the number of doctors undergoing training was increased by 100, and that is critical. In 2018-19, we will be able to see some relief in the healthcare personnel, and now with the increase of 100 doctors, shall we increase more? We still have time, but in the coming few years we will be up against this manpower shortfall. And this leads me to the second question raised by Dr. Zheng. If we have manpower shortage, and if we split up the service in 2 different places, the efficiency would be even lower. So we for NT East, we focus on the obstetrics in the Prince of Wales Hospital, and also United Christian Hospital, because if we split up the manpower for 2 different hospitals, then the service capacity will be halved for these hospitals. We don't have the scale of manpower. It will be very difficult for the patients. The quality of service will be even poorer. Mr. Poon Siu-ping. Chairman, thank you. The expansion and redevelopment of public hospitals will be supported by us because it will be better service. The Ka-lau and United Christian Hospital will be expanded. I understand from the patients that some of the services will be diverted to Ka-lau Hospital. Do you have any guidelines to make sure that the level of service will not be compromised? Because if redevelopment is going on at the same time in these two hospitals, there will be impact. And Para 17 mentions that in Yunlong, Twin Boon, Hong Shui-kiu, there will be 40% of the population living there. So how big is that hospital to be built? The manpower is very, very tight. With these redevelopment, do you have a specific plan to project for the right level of manpower? Secretary. On the second part of the question, Mr. Poon mentioned Hong Shui-kiu. Now, this is further down the road. It doesn't happen in the coming few years. And we do have land reserved in Hong Shui-kiu. But Hong Shui-kiu is closer to Tin Shui Wai. Our view is that the Tin Shui Wai hospital is about to be built. It is not a big hospital compared with the size of population in Tin Shui Wai. In Tin Shui Wai, Hong Shui-kiu, the population will increase. I would rather focus on the redevelopment in Tin Shui Wai instead of having two small hospitals in two different places. But in Hong Shui-kiu, there might be a need for a hospital, although not necessarily an acute hospital. Now, in our blueprint, this is something that will happen further down the road. I cannot be specific about the details, and I can let members know about our consideration, though.
As for the second question, I'll pass it on to Dr. Cheung. As for the expansion of Ka-lau, it will be completed by the end of this year. As for UCH, it's now being planned. Completion will be by 2012, said the speaker. I think that is coordination. During the expansion of UCH's service has not been affected. Only the quarters are being demolished, and then for the construction of an oncology department, and it doesn't affect the hospital beds or the wards. Next, Mr. Cheung Kok-chi. I have read the paper thoroughly, but I cannot give any comment because I only see the woods. I see the trees, but not the woods. I think the administration should give us a list, listing all the hospitals, their locations, the distribution of population, the nature of service. Say some hospitals may be good at kidney or liver transplants, and we should also be told of the number of the clinics, so that we can know the shortfall and in what area. Or a hospital is just operating at half of the capacity. We need to see the whole picture. Now, when we know the number of hospitals, we should also be informed on the number of doctors and nurses. If we just have these a little bit here, a little bit there, some will be built after 5 years, and then some will be completed after 3 years. Well, just a bit here, a bit there. I only know what is happening here and what is happening there, but I cannot see the whole picture. Chairman, I hope that with your wisdom, please tell what we asked for. Please tell them what we asked for. In fact, I've jotted it down. I've jotted it down. The administration has not told us the number of hospital beds. Say, in Kowloon Central is 1.3, but in Kowloon East is different. Now you adopt a cluster approach. Tell us the population of each cluster and also the projected population distribution in the next 5 years, and then number of hospital beds in each cluster according to your plan. How many hospital beds in each cluster? Will there be adequate number of hospital beds in each cluster to cope with the population? Yes, number of hospital beds in a cluster in a district. Now, if a hospital is adequate to provide a full range of service, but the hospital is not making full use, then we should put more emphasis on that. Concerning Mr. Cheung's question, your question is reasonable, but because of time constraint, if I'm going to answer all your questions, that will mean repeating to you all the service of the hospital authority. It cannot be done within one meeting. Well, after today's meeting, I don't ask it for today. I ask it today. Well, Dr. Cheung will provide information to you. Next, Mr. Chen Hangban. Thank you, Chairman. The administration has indicated that it wants to do something in terms of redevelopment and expansion. We are concerned about manpower. We have no roof over our head. Many people worry that, and we are worried that there will be too many hospitals. Concerning the expansion programs, after they are completed, will there be adequate doctors and nurses to man those hospitals? When will you be able to complete your manpower planning? Do you have manpower planning for that? In some districts, they may be covered by 3 network clusters, and then it will become a confusion. Say, after the completion of Tung Chung Hospital, together with the Tuen Mun Chai Lap Kok link, then the time to travel to PMH will be far longer than traveling to TMH. So those in Tung Chung may go to TMH. So is there a plan to redraft the boundary of the clusters? Dr. Ko, as far as overall manpower is concerned, we have a steering committee. At the end of this year, the steering committee will make a report on manpower planning. As far as the number of doctors is concerned, I can tell you, broadly speaking, in the coming few years, the situation is very serious. It will only be by 2018-19 there will be a better balance. It's not that we are doing nothing. In fact, the hospital authority is trying every means to retain doctors, to recruit part-time doctors, to recruit retired doctors to work full-time or part-time. And if you look at the media, you know that we are talking to the Medical Council on how to enhance the licentiate examination so as to attract overseas doctors who are trained overseas to come back to Hong Kong, in particular Hong Kongers who are trained overseas. And after with that's the situation. And we need to wait for that manpower planning report. Next, Mr. Wu Chi-wai. Yes, I can see some sort of a roadmap in the paper. The hospital authority is operating in form of clusters. Now you have a large full-service hospital working together with smaller hospitals so that doctors can specialize and therefore the quality of service can be enhanced. I think that direction is worth supporting. As for Kowloon East, I'm concerned about the full-service hospital in Kai Tak, and that is also related to reviewing QEH and also Lady Maryknoll Hospital. Anyways, I'm glad to hear the positive reply. As for the positioning of Lady Maryknoll Hospital, OLMH, I don't know when the review will be completed. Now there is also a healthcare center next to it, or a clinic next to it. If you take that into account, then the OLMH may have more land resources available if you take that review together with the clinic next door or nearby. As for redevelopment of UCH, I know that is on the agenda, but our concern is that the redevelopment may affect a service provided to the residents in the district. I know that you're experienced, but can you send a message clearly to members of the public that in the redevelopment of UCH, service quality will be upheld? Dr. Ko, let me briefly answer Mr. Wu's question with regard to OLMH. Because of the decision in respect of Kai Tak, the hospital authority is reviewing the future functions of OLMH. Because of the constraints, OLMH will not be moving towards an A&E hospital. It will be focusing on ambulatory service as well as convalescent service. I hope you will not just look at the hospital and the clinic only. As for UCH, as said by Dr. Chang, the part that is to be redeveloped is not housing the facilities for the acute hospital, but anyways, it will have some impact, and Cheung Kwan O Hospital may need to be adjusted to help, but the hospital authority will manage the transition well so as to minimize the adverse impacts. Next, Mr. Albert Ho. Chairman, I share the same concern as Mr. Cheung Kok Chiu. In planning your redevelopment and expansion, you should also look at the future few years. You need to make sure that these expanded hospitals and new hospitals and new beds will rationalize the distribution of resources. In terms of numbers, the distribution of resources among the clusters is not reasonable. You need to explain why there are such differences. Say, in certain certain hospitals, certain district hospitals are providing territory-wide service. So how much is for the district and how much is for the territory? And so that the service per capita is reasonable or equal for each district. Otherwise, some residents are regarded as second class because they receive less service. There'll be a debate in Wednesday. And maybe it's for the disbandment of the hospital authority. I'm not asking for that, but you need to rationalize the distribution of service. Let me now turn to KCH. Now let's hope that the mental patients can be reintegrated into society. The policy is there, but to implement that, you need a lot of related arrangements. Do you have adequate manpower to make sure that the medical appointments will be adequately provided and they can be cared for in the community, and if there is any relapse, they can still be dealt with efficiently? And as for ambulatory service, well, you really need to do it in different districts. They can't travel a long way to KCH. If it is a hospital, you can focus it on KCH, but if it is ambulatory service, then do you have enough clinics? I believe Mr. Ho is aware of this. With regard to community service and social workers, that is in relation to the cooperation between the welfare system and also the healthcare system. We are conducting a review on mental wellness or mental health, and the review covers the best approach in terms of caring for mental patients. Now, the ambulatory centers have to be present in the districts.
Well, on the second question, I'd like to say that the mental health service in Hong Kong, historically, members are aware that we moved on from a highly concentrated service to a new model. Now, when I was an undergraduate, the mental patients were concentrated in the Castle Peak Hospital. Upon the creation of the hospital authority, the mental health services have been scattered in different districts, but this is something that will take about a decade to achieve. I think you've got a point there. The distribution is not widespread enough to allow us to have this kind of service in every single district. Now we have moved on from the centralized approach to a cluster approach. It would take a bit of time for this to be completed, so I cannot say that the ambulatory services are well balanced, but we're moving in this direction. Mr. Ho, now you're trying to minimize the hospitalization. There may be potential danger. Secretary, now we have really gone past the stage where we reduce the hospitalization in a massive manner. We don't really want to see any massive reduction in terms of hospitalization. Over the past decade, we slashed quite a lot of hospital beds. I don't really want to see the hospital authority carry on slashing the number of beds. We have to strike a balance at a certain point. Dr. Joseph Lee. Chairman, thank you. Well, this item is about the redevelopment and expansion plans of the public hospitals. There are so many grand ideas, and the manpower shortage of doctors will not be relieved until 2018 to 19. So in the coming 10 years, with this blueprint available, how many beds, additional beds would there be arising from these expansion and redevelopment projects? Are we going to have enough manpower to man the hospital beds? Now, you should have some plans about the manpower, and doctors will not be enough until 2018 to 19. I'm not sure about the nurses. I heard from the hospital authority that in 2014, 2015, they don't have the funding for additional nurses. Now, that's what I heard from internal meetings. I like the feeling that you have enough nurses. And also heard that the hospital authority has spent about 5 years to work out the workload ratio index. So when the funding is dispersed, it will be on the basis of this index. So that presumably there would be enough manpower available. Now the ratio is 1 to 6. This is unique in Hong Kong, unlike other jurisdictions. I'm pleased about it. But are we going to have enough manpower for nurses? You have this decade-long redevelopment program with additional beds. I'm not sure whether you have enough manpower. So through the chair, I'd like to put this to the Secretary. Secretary, you said that you will not allow the HA to slash beds. We are gratified to hear that, but the review will be completed. I mean, I'm concerned about the manpower anyhow. Secretary, I did mention in passing that in the coming 5 to 6 years there will be shortage in doctors, and in the previous term the number of the quota for doctors training program has been increased. Well, Secretary, I'm talking about nurses specifically. Secretary, well, I also mentioned that the training lead time for nurses would be a little bit shorter, so the cycle is not as long as that for training up doctors. This year or at the beginning of next year, we are going to see a clearer picture. All the plans I mentioned in this paper will not come to pass for 10 years. So there is an opportunity through the strategic manpower planning to give us a clearer picture for us to plan for the level of manpower and the training needs. Mr. Albert Chan. Chairman, thank you. I'd like to take this opportunity to thank Dr. Ko for offering assistance to Mr. Raymond Chan. I mean, you received really wonderful praise on the web in the blogosphere. I mean, my grateful thanks to you. Chairman, I don't think I can extend similar gratitude with regard to this paper. When the AOs draft the paper, I believe this is a paper drafted by the AO, it is a failure. This is more like the Mr. 689's image. He is trying to blow up the projects which are really misleading. If you look at the hospitals in Hong Kong, like the chairman said earlier on, we do need to have a detailed paper telling us the ins and outs of the situation. All these hospitals have their own unique problems and the historical problems. In NT-West, they are inherently inadequate, and they are not really providing enough services. There is an upsurge in population in NT-West, and people are getting poorer, and people's health, state of health is also getting worse because of their poverty. It is difficult for them to patronize the doctors in the private sector, and the situation is so dire. In the Tuen Mun Hospital and also Pok Oi Hospital, inherently there are so many problems. If you cast a mind back to the construction of the Tuen Mun Hospital, the government didn't have that much funding as we do now, and the population is was also different from what we have today. If you go back in history, you would understand how difficult the situation was, and the personnel in charge of the project couldn't come out and talk about all the agonizing difficulties. Doctors and healthcare workers don't really want to work in Tuen Mun Hospital because of all the inherent problems. It would be like a ticking time bomb, and the bomb, as it were, is buried underground, very, very deep down. Now, Secretary, I'm wondering how you respond to this particular issue. You have the redevelopment and expansion plans. I think you have to identify the problems. I understand that the Pok Oi Hospital is undergoing expansion, but there are historical problems for different hospitals. You have to wield on life and carry out some kind of operations. It's just like the cancer cells that are killing the people in these hospitals. Secretary, in Tuen Mun Hospital or NT-West, there is indeed the problem that is being examined in the review exercise. The chairman has also highlighted this, and that is the distribution of resources between various clusters. The HA already explained that different hospitals serve different purposes, and they are serving patients coming from different districts. So how do we strike a balance? And there I think we have to sit down with the hospital authority and look at the statistics. And in the 20th anniversary review, we have to look at the utilization of resources between different clusters and the efficiency there. There is another problem in NT-West in the form of the Tin Shui Wai Hospital. The Tin Shui Wai Hospital and Pok Oi Hospital have their own inherent problems. They're not large in scale, and the cluster management may focus the resources on large hospitals in order to maximize the efficiency. So one of the reasons is that for a hospital of this scale in Tin Shui Wai, there may be problems. Now, with an increase in population in Tin Shui Wai or Hong Shui Kiu, I think the Tin Shui Wai Hospital should be expanded to achieve a certain scale. Dr. Kwok Ka-ki. Chairman, thank you. I heard what the Secretary said, and I beg to differ. The administration gave the undertaking about Tinshui Hospital, North Lantau, and Dongzhong Hospital. They gave the undertaking that they're there to cater for the needs of the residents in the localities. I don't really want to put words into your mouth. In the previous administration, they also talked about this being a comprehensive hospital. Now, the Secretary seems to be reneging on the words. The hospital in Tinshui seems to be of a smaller scale than what you made it out to be, and you seem to be saying that you may not be able to achieve this even if you are forced. Now, if you do not provide all the manpower, you should try your best nonetheless. The outpatient specialist care in Tinshui and Dongzhong, North Lantau, medicine, surgery, they will not become available until 4 to 5 years in operation. I think you were deceiving the residents there at the beginning. I'm not sure whether it has anything to do with the tendering for new hospitals. The new hospitals, there will be a demolition sooner than other hospitals. Prince of Wales Hospitals is a case in point. I'm not sure whether there are any problems with the tendering exercise. For the newly constructed hospitals, there are so many problems. I don't know whether you can address that. Now, we're spending billions of dollars on the new hospitals, and after a while, you have water leakage problem and all the rest of the problems, like Prince of Wales Hospital. You mentioned the QEH. I don't know whether a decision has been taken for Kowloon East.
We told the administration that there aren't enough land for private hospitals. We asked the administration to provide 2 sites. One in East Kowloon, Cataract Development, and also in one in West Kowloon for private hospital. Does the administration tell us that there will be none? We should forget about it. 3 questions. I don't understand concerning the scaling down of service. I don't quite understand his question. When I explain Tinshui, I think my understanding is to the contrary of your understanding. I'm talking about now. I want to clarify this. Now, he said that in the future it will be expanded. But you have to complete Phase 1 in 2016. I'm not commenting on the current service. Mr. Kwok, to Dr. Kwok, we're talking about long-term hospital development. Now, you're concerned the short lifespan of new hospitals. PWH may not be a good example. Phase 2 is not a good example. In the next phase, the quarters will be demolished, and then we will put up another hospital building to provide service. Concerning PWH and QMH, or rather PMH, the design was rather old and conservative, and with the expansion of service, it would be difficult for the hardware to accommodate. But if it is in respect of the Eastern Hospital, the Yode Hospital, Family Yode Hospital, and other newer hospitals, the use of space is more flexible. PWH doesn't PWH for phase 1 of PWH, we've already demolished the old ones and built a new one. And phase 2 is not the problem. Now, concerning a full-service hospital at Kai Tak, we're going to provide one, and therefore we may not have land for a private hospital. And we try to find a balance between the public sector and private sector. In the coming 8 to 10 years, there will be a substantial increase in hospital beds in the private sector. In the coming 8 to 10 years, the number of private hospital beds may increase by 30 to 40%. On the district level, we may look into that further. In Kowloon East, there is a piece of land on which a new private hospital may be built because one of such a group is asking for that, but we are still talking to that group. This is in a very early stage. Now, can I ask for a second round? We have overrun by 25 minutes and we still have one topic outstanding. Well, it can't be completed even for 3 days and 3 nights. You still have to come back to us. Mr. Chung says that he doesn't see the numbers, the full picture, say the change in growth in population vis-a-vis the distribution of hospital beds by cluster. We really need to have such data for a better understanding. Okay, we certainly provide that. Okay, next. Improvement of doctors' working hours in public hospitals. It's about manpower. Are you ready? The Undersecretary. Oh yes, thank you. This is the improvement of doctors' working hours in public hospitals. I'd like to report to the panel the latest situation of doctors' working hours in the hospital authority, and also the progress of implementation of reform strategies since the release of the final report on doctors' work reform in April 2010. In 2006 and 2009, the hospital authority conducted 2 reviews on the working hours of the doctors. And it was shown, or rather, the average, the percentage of doctors working for more than 65 hours declined from 18% to 4.8% from 2006 to 2009. As for overnight on-site on-call doctors having immediate post-call time off increased from 65% in 2006 to 82 and about 85% in 2009. As for the working hours of doctors, the review is done every 2 years, and in 2009, the 10 specialties in which doctors work for more than 65 hours per week. Such specialties will have to report the working hours on an annual basis. All the specialties have completed the collection of data in the 26-week reporting cycle. And in fact, in 2009, among all the specialties, about 4.8% of the doctors work more than 65 hours per week. And within the 10 specialties, about 8% of doctors worked for more than 65 hours per week on average. In 2011, the percentages remain the same. This year, between July and December, the hospital authority will conduct a next round of full-scale monitoring. We've seen that there is no substantial decline in the number of working hours of doctors, but the level is maintained with aging population, rise in medical technology, and also rising demand for service. The manpower requirement also increased. In recent years, the number of local graduates has declined. There is a serious shortfall or shortage of doctors, as shown in Annex 3, with regard to hospital service, ambulatory service, and also clinic service and special clinic service. There is a significant increase in number of patients. And in the same period, the number of doctors, the increase in number of doctors is far slower than the increase in number of patients in those areas. To enhance morale, a series of measures have been introduced, including recruiting part-time doctors, improving promotion, improve the on-call compensation, monitor wastage rate, set up acute wards, and also provide clerical support to doctors. All the details in paragraphs 11 to 17. And because of the acute shortage of manpower, doctors in public hospitals are dedicated to their service, and I would like to take this opportunity to thank our doctor colleagues for their contribution and commitment. I and the colleagues of the hospital authority will answer the questions asked by members. Thank you. Thank you. 3 members have raised their hands. Hands, please. A show of hands, please, and be steady. 3 minutes each to play safe, and if there is more time, you can have a second bite of the cherry. Mr. Poon Siu-ping. Now, we are fighting for legislation for standard working hours. Doctors work long hours because of shortage of manpower. You have a number of measures to try to put a cap on the number of working hours of doctors so that they will not exceed 65 hours per week. I don't know whether there is an international standard for number of working hours for doctors. And can you be more specific? Do you have any specific measures to deal with the situation? And if you can get adequate more manpower, will you lower it to 60 hours? And also, concerning civil servants who are in the hospital authority, I don't know whether there are. What are their working hours? Because civil servants are working 44 hours. Concerning your first question, my understanding is this. In the international, there is no international standard for working hours of doctors. Different doctors have different duties. And with regard to the professional training of doctors, before a doctor become a specialist, different academies have different requirements for training hours and working hours. We know that we must have a cap on the working hours of doctors, and therefore we have made a decision on 65 hours. And the hospital authority is moving to a set target. Perhaps Dr. Cheung can supplement. Well, in fact, that is a story. In the past, doctors work long hours. After the review or after the reform in 2009, we hoped that we can move the first step, and that is to cap it at 65 hours per week. And the doctors should not work for a continuous period of 24 hours, of more than 24 hours. We can only achieve that, and we cannot further shorten the working hours. As for, say, by 1819, there will be more graduates, and we hope that there can be an improvement in service. As for the working hours for civil servants and non-civil servant doctors, they work as a team, and there is no difference. Next, Mr. Chen Hang-pan. Working hours are related to the manpower situation, and it is a vicious cycle. The less the number of doctors, the more the working hours. For more remote hospitals, such as Shimon Hospital and North Lantau Hospital, doctors may have to travel a long way to the hospital. So in respect of doctors traveling to remote hospitals, can there be more incentives given to these doctors? They may otherwise, such hospitals may have recruitment difficulties. As for part-time doctors, what is the situation? Is there any progress? Do doctors who have left authority want to come back to work for the hospital authority part-time?
Dr. Cheung, well, for remote hospitals, it would be difficult to attract staff there. I think we have to consider the training. If a doctor doesn't get the Academy of Medicine's qualifications, it would be difficult to attract the doctors. So we have to make sure that the training we measure up to the Academy's requirements. Transport is also another problem. We may be partnering with some of the major hospitals for some personnel to be transferred from one hospital to another. Prince of Wales Hospital used to be a remote hospital, and now it is not. So there is a process to go through. For part-time doctors, since we have standardized the arrangement, we have proactively invited the outside doctors or the retirees to work for us on a part-time basis. We have 290 doctors that have joined on a part-time basis, with doctors proceeding to retirement. We'll liaise with them for them to come back on a part-time basis. Dr. Kwokaki, I've learned from the paper that the working hours have been coming down. It would be difficult for us to have a standard. It is 48 hours in the EU. In the US, as we are aware, there is no standardized hours per se. They tend to work pretty long hours. The manpower level may not be improved in the near term, for orthopedics, neurosurgery, surgery, obstetrics. They have to accumulate experience through these on-call duties because by artificially reducing the hours, it may not stand them in good stead because they haven't got enough caseload to learn from. The HA has equal pay for equal work. Now you have the honorarium, but that doesn't pay for the extra hours. You have an additional $4,000 or something for the honorarium. I think you ought to come clean and tell us that for certain specialties there may be greater demand, and you have to compensate them in terms of honorarium and promotion prospect. Now, some doctors have to work in remote areas. They have to spend time commuting. If they're working in Dongchong, for instance, they'll spend an hour for the commute, and that would increase their burden. It's not just a problem for the doctors, but also for other people who are not living in the area. For the support staff, you may be able to recruit locally, but nurses and doctors, you can't normally recruit locally. If you do not change your mindset, it would be difficult for you to recruit. So would there be any revision to the terms and conditions with a view to enticing the healthcare personnel to stay in certain specialties? I heard that certain hospitals find it very difficult to recruit for the surgery discipline. Some would much rather work for less demanding specialties, and this is not good for the long term. Under Secretary, thanks very much, Dr. Kwok, for the question. The HA has been recruiting doctors. They are trying to retain doctors, and also they're trying to improve the working hours and the working environment for the doctors. Well, I'm not asking about that. I appreciate that. You're asking for specialties for which recruitment is more difficult. What measures do we have? I defer to Dr. Zhang. Chairman, obviously to attract doctors for particular specialties, there can be many different factors. The first one is training. The second one is the career prospect. The third one is the working environment, and working hours would be part of that. Over the years, we have been liaising with the frontline doctors, and doctors from different specialties offer different input. But there is a consensus that the working hours may not be the sole consideration, although this is not desirable if they are exceedingly long. So we do offer honorarium. There will be 3 tiers instead of 2. And that caters for the exceedingly long hours. And we have the phlebotomist, we have the care technicians to lighten the load of the doctors. We don't really want to see a vicious circle regarding the long working hours. We are liaising with the front line to deal with the problems. We would like doctors to pick up different specialties in a more balanced way. Mr. Albert Ho, I am more concerned about those working more than 65 hours per week. Now, this is an average figure. In the worst case scenario, the situation can be more serious. Now, in one of the hospitals, I heard that they have a serious problem in the obstetrics ward, and some doctors are on maternity leave, and they are really suffering from a very desperate situation. Can you redeploy some of the staff over to these hospitals? I think you are doing this already, and that is you're hiring some retired doctors, some consultants who have retired, 60-year-olds or something. They're pretty young for a doctor. They have the vitality, they have the energy to carry on working. Some of them are not moving on to private practice, and they do have their mind to offer their help. I think you should pay them well enough. I heard that they are paid on the same level as an MO, or 70% of an MO. I mean, they're doing it as a favor. They can't bear to see their colleagues suffer so much. Some have to drive a long way to do this part-time work. I think you should pay them in a decent manner. These part-time doctors do have the expertise and experience, and they can mentor the new recruits, and these are really available pool that you can tap into. Why don't you maximize the potential there? Under Secretary. Chairman, thanks very much, Mr. Ho. The recruitment of retired doctors, given the manpower shortage, is something that we have already begun. A lot of retired doctors do not come back just for the money. Now, 70% of an MO, I mean, why do we pitch it at that? Perhaps I defer to Dr. Zhang. Say, for instance, the consultant doctor, he has retired. We would pay him 70% of the pay for a consultant, but he doesn't have to do an on-call duty overnight. He would be doing the outpatient service, not so much making rounds in the wards. Now, these are retired doctors. Probably they have their own clinics outside. It would be difficult for them to offer the service on a full-time basis, and they would be able to mentor the younger doctors, and they'll be sharing out the workload in the outpatient clinics, and the pay would be 70% of what a consultant would get paid for, but they don't have to do all on-call duties. Now, in Prince of Wales Hospital, the A&E is suffering from a very serious problem and asking for reinforcement. But the key thing is to retain the manpower. Now, for specialties with greater pressure, we will deploy the necessary manpower. Mr. Ho, I will pick up on this in just a moment, if time permits. Ms. Helena Wong. Chairman, thank you. I'd like to bring up this attrition rate. In the 1990s, or mid-1990s, the attrition rate was anticipated to be 1% or slightly more. Right now it is 4 point something percent. So obviously there was an error in the projection. In mid-90s, there was an argument that there was a surplus of doctors. The medical association suggested that in 1989, the number of doctors be slashed in university. The wastage rate was 1.9. Now, in fact, the attrition rate is 4 point something percent instead of 1.9%. We don't have enough doctors, and that explains that over time work for the doctors, they have to work longer hours, they have to work more to make up for the shortfall. You have a whole raft of measures. You have the retired doctors coming back, and you're recruiting doctors from outside of Hong Kong, and you will be admitting more undergraduates for medical school, an additional 100 per year. With more undergraduates, that would not be anywhere near enough for the short term. Now, with all these measures in place, if we look ahead for the coming 5 years, how much impact will these measures have on improving the working hours and also the ratio of doctors. In 2011, the Medical Council has 12,000 doctors on the list. In other words, there is 1.8 doctors per 1,000 people. According to the OECD, in 2008, by comparison with other jurisdictions in the UK, per 1,000 population, they have 2.6 doctors. In the US, 3.1, Japan 2.2, South Korea 2.3, Singapore 2.2. At the moment in Hong Kong, we have a ratio of 1.8 per 1,000 people. Now, in all these jurisdictions that I mentioned, we are faring worse than them. Now, with all these measures in place, peering ahead for 5 years, what is the ratio between doctors and patients? Can we catch up with all these other jurisdictions? Under Secretary, thanks very much, Madam Wong. The first question is about the projection of attrition rate. I think the wastage of healthcare workers remains a projection. In Hong Kong, we have the private as well as the public sectors. When the private sector is booming, the healthcare workers in the public sector may drain away. I mean, this is a natural development. Be that as it may, we are working proactively to understand the demand in the private sector. In our manpower review committee, other than the public sector, it is also examining the situation in the private sector. Because of commercial secrecy, we may not be able to get to grips with all the minute detail, although we are trying very hard. We're doing so in order that we will end up with better projection in terms of the attrition rate. On the second question, going forward, what's going to happen? Perhaps I defer to Dr. Zhang.
Well, concerning the resignations, there are 3 reasons. First, the prosperity in the private sector. Number 2, retirement. Now, during this period of time, there are more doctors reaching retirement age. So in the coming few years, there will be more doctors retiring. As for future increase in number of medical graduates, will there be adequate doctors? Is a very complicated issue. Now, the Director Bureau has a steering group looking into that. I think the major problem is not the doctor-to-population ratio, but aging population. We need to consider the aging population. And our geological situation is rather different. We are small, and we have the economies of scale. It's easier for us to go to different parts of the territory. In, say, Australia or the UK, people may have to travel a long way. That's different. That is a different situation. But there is a steering committee looking into manpower situation. It's my turn. Perhaps I allow Mr. Albert Ho to follow up his question on part-time arrangement. Many part-time doctors don't work for long hours. He may just work for 1 or 2 days a week or a few hours a day, but they are committed. They don't do it for money, or many of them don't. I think it's reasonable to give them a reasonable pay. They have very valuable experience. Some retire may not be at the rank of consultant doctor, but just a SMO. and it's I think reasonable to give them a better pay, and also give them a certain allowance if they go to a remote hospital. You shouldn't ask people to do it on voluntary terms. I think I may add a bit. Now, concerning consultant doctors, they are paid 70% because they don't need to be on call. But for full-time consultants, they don't need to be on call, though they can be said to be on call in name. Why you just pay them 70%? They should be paid the same hourly rate as consultant doctors instead of just pay them 70% of the hourly rate of consultant doctors. Yes, I understand Mr. Ho's point. This will encourage the doctors who have left to take up part-time appointment with the hospital authority. And we should give them a reasonable pay. But we have this consideration. We don't want to give incentive to full-time doctors to switch to part-time. If he doesn't need to be on call and he's given a pay that is equivalent to his full-time rate, then many doctors will switch to part-time instead of doing full-time. We think the present arrangement is able to attract experienced ex-colleagues to work for us part-time so that they can pass on their experience to younger doctors. I will keep an eye on the situation and conduct a review if necessary. Many don't work for long hours because they are retired. They have retired. Now, you were a consultant doctor, but when you come back, you do everything. It's not a matter of money. Will people just resign and then switch to become part-time? You were doing full-time. You have a lot of experience, and now you've worked part-time, and you are to take up jobs which you don't take up duties which you don't do, which you didn't do when you were full-time. Well, you're afraid that if the hourly rate is the same, then the full-time will switch to part-time. One reason is that you are unfair to the full-time, because full-timers, because the full-timers are on call and they don't have extra compensation. Now, if you are good to the full-timers, if they work longer hours, they get more pay, then they will not switch to part-time. When they switch to part-time, they don't have any job security. I think that's really a deadlock. If you don't have a pay system that commensurate with the quantity of work, then you really can't release manpower to deal with the situation. In the private sector, no doctor has complained for long working hours. Many doctors in the private sector work long hours because they work more, they get more money. There is no complaint. The crucial issue is manpower management mechanism. You may say doctors' basic pay is very high, and therefore you cannot give them more pay for working overtime. But if you can start from a clean slate, how much salary has to be cut in order to introduce a pay system that commensurate with working hours or working quantity? Now, we do have special allowance. Now, concerning this special allowance, the OT pay is smaller than the normal hourly rate. That's not effective. It's higher. It's higher than the normal hourly rate. There are different factors involved. We've talked to our colleagues. working hours working hours aren't everything. We really need, I think the most important thing is to get a consensus with the frontline doctors. As for some specialties, the working hours may not be very long, but they have a very onerous job. And also there is the question of distribution of manpower and distribution workload. Say, there may be a lot of doctors for a particular specialty and very few doctors for another specialty. These are the things we need to look into. I think the points raised by the Chairman and Mr. Ho are also worth looking into. Thank you. Any other questions? Ms. Helena Wong. Chairman, I want to follow this matter up. The reply by the Bureau is that Hong Kong is different in other places. They have patients have to travel a long way. But in Singapore, it's equally small as Hong Kong. But in Singapore, the ratio is 2.2 per 1,000. Hong Kong is just 1.8. We need to catch up. I don't know how effective the present measures are. At least we shouldn't be worse off than Singapore. I want to know, after you have implemented these measures, do you expect that the working hours of doctors can be improved and the doctor-to-patient ratio can be improved, at least up to more than 2 per 1,000? Or do you need more resources and more measures? Dr. Chung or the Undersecretary? Well, I'll say a few words first. If we look at the measures as said by Dr. Chung, and if we compare the situation with 2006 and 2009, we can see that there is an improvement. But this is not a target. 65 hours is not the target. And we hope that the number can be reduced. But at present, with the current manpower situation, that's so far we can go. As for the demand for service, it is increasing because of aging population, because of the aging population. And in fact, members of the public and members of this council are making more demand on the doctors. And that's something we also have to take into account. So if you say we can introduce, if we have these measures, what target we can achieve, I think that's something the hospital authority is watching all the time. Now, by 2018-19, with the increase in number of medical graduates, the doctor-to-patient ratio will improve, or the doctor-to-population ratio will improve. But we will face a rapid aging population in the coming 20 years. Even if we have more doctors graduating per year, can the situation improve? And that really is something the steering group can say. As said by the Director of Bureau, he will give you the report at the end of this year. I have a follow-up question. Now you have more graduates, and if you can recruit them into the hospital authority, that's okay. We have no objection. Now in 1998, 1999, the economy was poor, the administration cut resources. But you really don't know the future. By 2018, 2019, if the economy is poor and the hospital authorities suffer a 10% cut. Now let me put it this way. If government revenue is reduced by 10%, can the hospital authority employ all the medical graduates? by then. Do you understand my question? Now, during those years, government revenue declined by, say, 10 or 20%. Therefore, the resources for HA was reduced. Therefore, medical graduates became unemployed. Now, by 2018-19, there will be 420 medical graduates. I'm worried that there may be 200 medical graduates who can't find jobs. Say, because of a downturn in the economy, say, for example, hard landing of the economy of the mainland, government revenue declined by 10%. Can you guarantee that there will be no cut to the hospital authorities' resources and it can recruit or employ all the 420 graduates? Now, that's hypothetical. Things are uncertain. But we will watch the situation and we will have the measures to respond to that. As for the increase in number of doctors, we take into account the availability of resources. In your planning, you will consider resources. Yes, let me wait for your report and see how you deal with resources. Time is up. If you don't have further questions, we'll draw a line there. We don't extend our meeting. Okay? I think concerning the manpower situation, I think the subcommittee on HSP or HPS rather, will follow the matter up. Any further questions concerning for today? If there is no AOB, then meeting adjourned. Thank you very much.